For this talk, we have Dr. Nitin Patankar. He is going to speak on behavior therapy, the case-based approach. Dr. Nitin Patankar, I think, does not need a big introduction. He is a known personality in the management of, in the field of obesity management, and he is from Mumbai. Dr. Nitin, over to you.
Thank you, organizers. Thank you, Dr. Neeta, Sanjay, for this opportunity to talk of behavioral therapy as a case-based learning. So what is behavioral therapy? The latest model is ABC model, where we talk of antecedents, which stimulate the behavior, and behavior leads to consequences, and consequences again shape your behavior. So these are the interdependent, a dynamic model of behavioral therapy. So this is what happens. Suppose in diabetes, obesity, or lifestyle disorders, most of the behavioral modification is circling around food intake and exercises, and some part is devoted to whether patient is compliant with the medicines. So let us start with a very simple thing. Someone feels hungry, that is an antecedent. Then he has two choices. Either there is a roti and vegetable is available, or he has a pizza available with him. He eats something and he feels full or satiated. So this is a very, very simple basic thing about antecedent, behavior, and consequences. So what behavioral therapy involves? Basically identify the behavior, which is an observable behavior that needs change, then try to modify the antecedents or the stimuli, which will change the behavioral pattern, or modify the consequences so that it will reflect back and the patient or the subject tries to change the behavior so that the consequences can be changed. So it is basically, this is repeatedly done so that ultimately the desired behavior becomes a learning and that becomes a habit. So that is the end goal of a behavioral therapy. So here in this case, the behavior is, instead of eating roti, the person is eating pizza. Now you can modify the antecedents. So what are the antecedents? The patient feels hungry. Now there are two choices, roti and vegetable and pizza. But what a very simple antecedent modification is, make pizza unavailable. So that whenever you feel hungry, you have only roti and vegetables available and you will eat that and feel satiated. So this is what a simple behavioral therapy model is. Then how to change the consequences? So the consequences, unfortunately, when the consequences are direct, immediate, and either they are rewarding or like a punishment, they have a immediate changes on their behavior. So, but in cases of lifestyle disorders, we have to first of all measure the consequences, because they are not apparent in terms of bodily symptoms, or it is not in terms of a general reward like it happens in addiction or punishment. So what we do is ask to measure the blood sugar levels after eating pizza. The blood sugars are high. We assume that the person is rational. He knows the effects of high blood sugar levels. And so this will act as a deterrent or a negative reinforcement. And the subjects will choose roti over pizza and keep sugars normal. So this is a basically change in consequences. And this is repeated many times till the desired behavior is learned. So patients avoid pizza and eat roti. Now let us come to the case. This is a Mrs. VK, who is a 45-year-old female. She is a bank employee, married with 2 children. Recently, that is 8 months prior to my first visit to a doctor, she shifted from Solapur to Thane. Husband and wife both got transferred to job Thane and Mumbai. The children are admitted to Thane school. This is what is her social background is, and which plays a great role in designing behaviors. Her height is 5 feet 5 inches, weight is 65 kg. Now, she was detected to be diabetes 6 years back in Solapur, and till last year, every 6 monthly, she was using biochemistry and her average values are HbA1c was 5.9, fasting PP was 94 and 126, lipids in normal range, and weight was hovering between 61 and 65. But in the 8 months after her transfer to Thane, her values are HbA1c has gone up to 8.6, fasting PP are 128 and 212, lipids are 234, total cholesterol, non-HDL cholesterol 154, and weight has gone up to 70 kg. So now she was taking medicines, metformin 500 milligrams twice a day and glimepiride 2 milligrams, on which she was totally controlled. So what are the present complaints? See, these are the biochemical reports, but when the doctor took a history, the complaints were not only about her rising blood sugars. She complained that she feels more hungry now, though she knows and prepares healthy calorie controlled diet because she was like taught about how to prepare a diabetic diet and always keep some meal supplements and healthy snacks ready. She still ends in eating more than required portion sizes, adds some junk food to many meals or snacks in a week, cannot say no to the frequent snacks, which is a workplace norm for her, feels lethargic and has stopped all kinds of exercises, worried about her rising sugars and lipids, as both her parents have diabetes and always suffered with diabetic complications and poor quality of life because of uncontrolled diabetes. So on a knowledge side, consequence side, she is aware. So what are the options for treatment? Increase and modify the medicines, plan a revisit to a dietitian in Thane, or plan an exercise program. So the doctor added SGLT2 inhibitor, DPP4 inhibitor, and voglibose. Dietitian plans for a Mediterranean diet with diabetes compliant, there is multiple small meals, but with the quality of the food which matches with Mediterranean diet, added meal supplements and SOS finger foods, which are healthy. So that when she feels hungry, she can eat that, and a gym membership was paid. Now, these are the reports after 3 months of this first visit when doctor modified everything. Her HbA1c has come from 8.6 to 7.7. Fasting PP, it dropped down to 86 to 122, but again has come to 101 to 153. Weight is just 2 kg drop, 68 kg. Diet compliance decreased over the time of 3 months, and gym, very poor presence in the gym. So again, the doctor has now these options: increase and modify the medicines or add insulin, plan diet variations, plan for supervised exercise program like keeping a personal trainer, and attempt to modify the behavior. So routine instructions for change of behavior. This is what usually advised by doctors or so-called counselors or even regular counselors who are trained. So when you feel hungry, drink some water, delay the hunger feeling. Keep food at some distance from where you are sitting. Keep healthy food ready and unhealthy food unavailable. Check blood sugars 1 and 2 hours after eating, and write down if the sugars are in normal range or good results, which can work as a positive reinforcement for healthy food selection. Then you do some experiments with yourself. Sometimes eat unhealthy food and see the sharp rise in sugars, which will work as a negative reinforcement, and the reinforcement will turn into behavioral choosing of healthy foods and a learned behavior. This is what is commonly advised as a change in antecedents or consequences. Now, how we start working? So we re-examine the basic antecedents or antecedent behavior. So what are the immediate antecedents why she chooses food is hunger. But lingering, when she came from Solapur to Mumbai, Solapur to Thane, it's a shift of environment and novelty and craving for particular foods, and that can be exaggerated by anxiety of relocation. And then the lasting things are her mood. In present case, there is a lot of uncertainty how she will adjust. Then there is a lot of insecurity because a woman coming from a small city to a big city, and she has to get adjusted to relocation, readjustment with new people, make a place for herself, and make all other adjustments. So there is a predominant feeling of insecurity in her, and there is a predominant anxiety. So these are the three antecedents: the hunger, and on the background there is anxiety and insecurity. Then we re-examine the basic consequences of identified behavior. See, when she feels hungry and eats roti, she feels satiated. But when she's feeling hungry and anxious, and she wants to feel comfortable, or she wants to take pleasure, she chooses pizza. Or sometimes she feel hungry and she is feeling more insecure, then she eats a larger quantity of rice and curry, which will give both or three things: satiety, pleasure, plus a sense of security. So these are the antecedents we have to tackle. Similarly, looking at reassigning the consequences. The immediate consequences are most important, that how are the emotions are manipulated after a behavior, how are the feelings, and what are the physical changes that take place. Now, we know that measured blood sugar levels, BP, or long-term HbA1c and weight, but the weightage given to these measured and long-term consequences are much lesser, because it is known that when you are into a turmoil, when there are some emotional antecedents, then the pain, the negative things are neglected, and you focus more on emotions, and emotions are felt in the body, and those emotional signals are represented as feeling in the brain. And that's why we have to do something to change the emotions. So what we need to do, what we have missed into the routine steps. In these steps, pre-antecedents like need for security, control of anxiety are not taken into account. Secondly, consequences like pleasure, adhering to socio-cultural norms are not given due importance. So what was advised? The patient was given combination of SGLT2 inhibitor, DPP4 inhibitor, voglibose, but insulin was not started. Mediterranean diet was continued. Home exercises were advised, and counseling sessions include not only cognitive behavioral therapy, but also we included rational emotive therapy or rational emotive behavioral therapy, so that we can tackle the immediate consequences. So CBT and RET takes multiple sessions and very long time to change into behavior. To shorten this time, we added yoga. For Mrs. K, depending on history, there are specific guidelines into yoga sessions or yoga practices. So her history suggests working with something called the root chakra. So after 3 months of a second visit, when she started this yoga plus rational emotive therapy, her values are 8.6, 7.7 for the second visit, 6.2 to the present visit. Fasting BP has come down to 90 and 134. Weight has come down from 70 to 62.8. She is now very well compliant with the diet. And whenever she feels like eating, now she can manage into very small portions of the food that give her pleasure. She can do a 5 days a week home exercises, and medicines are again reduced to glimepiride 2 milligram and metformin 500 milligram, which was a stable medicine when she was in Solapur. So some common pre-antecedents which we don't tackle, then it leads to continuation of self-defeating behaviors. So increasing number of medicines, not attending targets, and patient turning to alternative medicines, social media remedies, and social media influencers, or frank quackery, because we fail to take into account these antecedents, which are extremely important in behavioral therapy. So some common missed antecedents where the clinical yoga can help. So these are things which we have seen commonly. So for some people, life becomes routine. Each day is a copy of a previous day. There is a lot of boredom, and boredom can be a great stress. And to do away with that stress, people start choosing unhealthy behaviors. Then sometimes there can be irritation or anger at situations beyond your control, and feeling of helplessness. Then there can be lack of progress, failure to meet your ambitions, lack of time management skills. Then there is something called as a lack of empathy, lack of clarity and control, and sometimes the responsibilities are forced on you without adequate preparation. So these are the common antecedents that are present, which are the deterrent in behavioral therapy.
Dr.
So
Patankar, last 2 minutes.
yes, this is the last slide. So what I want to focus on is, we have talked about the legacy effect. And what we were talking about is like a socio-cultural or a personal behavioral therapy. But let's look at the legacy effect. Legacy effect is now not a, what you can say, prerogative of diabetes, but now it is seen in hypertension, dyslipidemia, and heart disease. So what legacy effect exactly is? So when we have, say for diabetes, we are actually changing the behavior of your mitochondria to produce so less damaging or produce a normal products rather than producing like glycation end products. So that's why first 5 years of good control of diabetes, after the diabetes is originated, then mitochondria change its behavior, the cell change its behavior to not respond to hyperglycemia in the same fashion. So that's why even the next 20 years, when the tightness of the diabetes control is not there, still your complications are lesser. So you can read the excellent lecture by Brownelly, who has shown that how the diabetes complications occur, and then what is the legacy effect. This was always at the back of my mind, that legacy effect is nothing but behavioral modification at cellular level, mitochondrial level. So my last slide will be, so this is what we are actually dealing with. So this is a, what you can say, a overt behavioral therapy. There are antecedents, behavior, and consequences. But we are talking of environmental and social level, something at personal level. But as a physician, we have to talk of behavioral modification at cellular, molecular level, and maybe at genetic level. So a branch like epigenetic, branch like molecular behavioral therapy will be the future of behavioral therapy in all lifestyle disorders. So that's where I stop. Thank you so much for giving me this opportunity to voice these views. Thank you.
Thank you, Dr. Nitin, for a wonderful presentation and making the concept of behavior therapy, so simple. Do we have any questions in the chat box? No, I don't.
I have a question.
Yeah.
So it's easy to say behavioral modification, doctor, but our children and our youth is living in an obesogenic environment. So the focus has to change the environment, not just the individual. So how do you go about changing obesogenic environments? We go to conferences, we have big meals. How do you avoid?
That's what I said, that whatever environment is there, it is always assessed. So there is a concept in behavioral therapy that the environment is judged by something called the brain maps. A neuroscientist called Antonio Damasio has described that, he has described it as consciousness and reality is actually your brain picture of what is happening in around you. And that's where the yogic practices can really work, the visualizations and all the yoga practices, so that you can change the picture of reality, and then your responses will change. So you cannot go and change environment. That is impossible. It is beyond your control. But you can change your internal picture of reality, and then your responses can change.
Thank you.
Dr. Nitin, one important question is that once we are seeing clinical practice, whether it is diabetes or obesity, we all understand it involves teamwork. You need to have a counselor, you need to have educator, some support people have to be there. You can't be doing everything. But that is largely missing in most of the clinics. So any suggestions on how to, overcome that flaw that is there in clinical practice in Indian setting? And also it is not reimbursed by insurance or anything. anywhere in India?
So this is again a very good question, and I have always been thinking on this. So I can take a cue from my previous lecture, I think Nambiar madam. So she said that the physicians have to learn even exercises. So similarly, all those things that are required for a good lifestyle modification or diabetes management, a treating physician can learn, say, a primary things. And the patient will always pay, or patient will always get to go to an expert or a second team member, which may not be under one roof, but once he sees the benefit of what you are talking about. But first thing is that should be into physicians, say, thinking sphere, that you need a dietary support, you need exercise support. So once I can say advise some exercises which will give some benefits, then I can tell if you can have more benefits, go to such and such person. So that is the way. Well, we have to improve our sphere of influence in all these fields. That's what I feel.
I have a question. I know you're doing a lot of work with yoga chakra, chakra meditation for changing behaviors. So
Yeah.
once, and it is rather customized. So that is the best part about it. So you take the history and all of that and do it customized. So what I want to ask you is, how soon after you institute yoga chakra meditation or yoga chakra behavioral therapy, how soon do you see changes in behaviors, and how well is it accepted?
4 weeks.
Okay.
And once you discontinue, do they last?
Yeah, for some time it lasts, but again, it is like an
Again, it has to be
process.
ongoing process.
Yeah, it is an ongoing process. So that's why most of the times the group therapy works.
Yes.
Right.
So I think we have come to the end of this session. If there are no more questions, thank you, Dr. Nitin, for a wonderful